members, if you could please, committee members, if you could please put a CM in front of your name. It helps us when we're doing roll call. How's it looking, Jessica? Still.
We are up to 29 participants. I think maybe we're good to go.
Okay. Well, again, good morning. Thank you for joining us for the November 6th, 2024 edition of the Healthcare Workforce Committee. We will go ahead and get started. Once again, committee members, you could please put a CM in front of your name for when we do roll call. It just helps me. And Jessica, if you could go to the next slide, please. And next slide. Okay, a couple of things, housekeeping items. This meeting is open to the public. We do welcome public testimony. The meeting is recorded. We will have live transcription available. Committee members, if you are able to turn on your camera, we would love to see your smiling faces. Again, we understand if bandwidth is an issue and you cannot, that's perfectly okay. And next slide. I think I already did my welcome. My name is Laura McKean. I'm the chair of the Healthcare Workforce Committee. I'm also the Senior Director of Oral Health Services and Community Engagement at All Care CCO down in Southern Oregon. And next slide. Perfect. Okay, I'm going to go ahead and do roll call for our committee members. And if you could just please say your name and organization that you represent, that would be great. And I am going to start with our Oregon Health Policy Board liaisons, and I will begin with Dr. Hemmings.
Dr. Hemmings, she, her pronouns. And was there a question for me to answer?
Just what organization you are with, Dr. Hemmings?
I'm here with Oregon Health Policy Board. I own a group practice in Beaverton, Oregon, Black Therapists and Company. Happy to be here.
Thank you, Dr. Hemmings. And Melina?
Good morning. My name is Melina Moran. I use she, her pronouns. I'm representing the Oregon Health Policy Board. I am also a nurse practitioner at Best Care Treatment Center.
Thank you, Melina. Ian?
Ian Strauss, I use he, him pronouns. I am the owner and principal consultant for Ian Strauss Consulting, a healthcare innovations consulting group.
Thank you, Ian. Once again, committee members, if you are here, please put a CM in front of your name so we can identify you for roll call. How about Elena?
Morning, I'm Elena Shablowski. I use she and her pronouns, and I'm a dentist and dental director at La Clinica, which is a federally qualified health center in Medford.
Thank you, Elena. And Gabby?
Good morning, everyone. My name is Gabby Carrillo, and I am with Sumner College.
Thank you, Gabby. Larissa?
Good morning. My name is Larissa Mejia Medina. I work at Road Community Health as the Quality Improvement Nurse Director.
Thank you, Larissa. Rob? Rob, can you hear us? You're on mute if you're talking.
Hi, Rob Ross. He, him. I'm a family physician. I'm the director of research and academics at St. Charles in Bend.
Thank you, Rob. Coy?
Hi, good morning, everyone. Koi Vu, pronouns she, her, hers, Executive Director of the Coalition of Community Health Clinics.
Thank you, Coy. And let's see, I'm going down my list. Committee members, who am I missing? I think I've gotten everyone on the list. Committee members, if I missed calling you, if you would go ahead and introduce yourself, please. Okay, I think I've gotten everyone. All right, we do have a number of guests with us today, OHA staff. If you would please type your name in the chat and your role, that would be awesome. I do want to go ahead and give a special welcome to Deepti, who is joining us. She's new. She's the newest staff member to the Healthcare Workforce Committee. I'm very, very happy to have her. I've had the opportunity to work with Deepti before at part of the PCPCH program. So welcome, Deepti. I'm very, very happy to have you with us. And we do have, you can see a number of OHA staff attending with us today. And next slide. Oh, perfect. Thank you. You can see we have a very, very packed agenda today, folks. So I'll do my best to give everybody on time. I know we have, there are times where we run a little bit over, but we'll do our best today. But we have some really important things to discuss today. So next slide, Jessica. Okay, perfect. As always in our monthly meetings, we do like to review the health equity definition and framework. If you could go to the next slide. And here it is. I do feel it's really important to recite this. Recite seems kind of a funny word, but I think it's important to review this health equity definition that has been adopted by OHA and the OHPB, and it states that Oregon will have established a health system that creates health equity when all people can reach their full health potential and well-being and are not disadvantaged by their race, ethnicity, language, disability, age, gender identity, sexual orientation, social class, intersections among these communities or identities, or other socially determined circumstances. And achieving health equity requires the ongoing collaborations of all regions and sectors of the state, including tribal governments, to address the following: the equitable distribution or redistribution of resources and power, and recognizing, reconciling, and rectifying historical and contemporary injustices. Oh, next slide, Jessica. And you can see here, this is a reminder. This is the Healthcare Workforce Committee guiding questions for equity framework. I'm not going to read all these questions. You have them in the meeting materials, but I do think it's really important to review them. And you know, the last question: how are we resourcing and influencing system partners to ensure programs optimize equity? And just from my perspective, from a CCO perspective, I think we've really delved into that, especially in the last few months with the HRSN benefit coming into play. So let's see, I do think we have a few more committee members that have joined us, so I'm going to pause really quick and see if we can identify committee members. If you have just joined the call, can you go ahead and just introduce yourself?
Judy Geiger, Vice President, Patient Care Services at Columbia Memorial.
Thank you, Judy. Welcome.
Hi, everyone. Alicia Jackson with OHSU, committee member.
Thanks, Alicia. Dr. Chaudhry, I saw you popped on.
Yeah, sorry, I'm not on camera yet. I ran late a little bit. My name is Dr. Manu Chaudhry, former, or not former, but dry finger dentist, and I have the privilege to serve as president of Capital Dental Care.
Thank you, Dr. Chaudhry. think that's it. I think we've got everyone. Did I miss anyone, committee members? Okay, perfect. Next slide, Jessica, please. Okay. Review and
This is
go
Jason.
ahead.
I just hopped
Oh,
on.
hi, Jason.
Yeah.
Good.
Sounds like we're doing introductions. Is that right?
Yes, we are. Go ahead, Jason.
Yeah, thank you. Sorry for being late. My earlier meeting ran over. My name's Jason Johnson. I've been a committee member for, I don't know, 5 or 6 years at this point. I'm a dean at Portland Community College, where I support a portfolio of healthcare programs. It's good to see everybody.
Thanks, Jason. You're running right up against me, Jason. We're like long timers here. I love it. Okay, so any more committee members? Okay. Review and approval of September meeting minutes summary. I hope everybody had a chance to review the meeting minutes. And go ahead, Ian.
So,
Were you gonna say something?
Pardon?
Were you going to say something? I'm sorry. I saw you come off mute.
Oh, no.
Okay.
Sorry.
If I could get first of all, are there any additions to the minutes, corrections? Okay. And if I could get a motion to approve the September meeting minutes, and then a second.
Motion to approve.
And I'll second.
Thank you. And committee members, if you just give me a thumbs up or an eye. I was not at the September meeting, so I will abstain from voting. Okay. Oh, Judy, I love your thumbs. That's so cool. Multiple thumbs. Okay. Thank you. Meeting approved. Meeting minutes approved. And next slide, Jessica. Okay. We are at our public comment portion of the meeting. I don't believe we had anyone sign up for public comment. Do we have anyone with us this morning that would like to provide public comment? You can raise your hand or come off mute, and we can go ahead and recognize you. And I can't see everybody, Jessica, so I'm not, if staff could help me.
I'm not seeing anyone with their hands raised, but let's look at the chat. No one is offering comment in the chat at this time.
Okay, perfect. Thank you. And next slide, Jessica. Okay, now we are at our Oregon Health Policy Board and OHA updates. And I'm not sure who's going to take the lead on that first, Neelam. So I will turn it over to probably maybe Dr. Hemmings and Melina for our OHPB updates.
Melina is actually the liaison for this committee. I'm here because I was a member before I became OHPB board member. So
Okay.
Melina, take it away.
Thank you, Dr. Hemmings. My name is Melina Moran, she, her pronouns, and welcome Deepti to the committee. So yesterday was our OHPB meeting. We did some housekeeping. We voted on our calendar for 2025. Wanted to remind everyone our committee digest Q3 is online. There are some announcements. One of the members, Carly Hood Ronick, is leaving the board, going on family leave, and then taking a new role with the CCO, Care Oregon. So we will have an open seat, and if anyone is interested, they could apply online. We talked about the progression of leadership. Next year, Kristen Isaacson will become chair and Tonya German will become vice chair. Next, we had the OHA director update. Dr. Hathi was represented by Steph Jerem from the OHA. So there's some exciting news. There is the expansion of tribal benefits and the approval for traditional health practices to be covered. This has been a project that's been working, that started in 2003. So it's very exciting that the traditional health practices will be covered by Medicaid. And Oregon is one of 4 states that has approved this. Previously, they've been covered with grants. The second announcement is the update on the 1115 waiver. This is the housing benefit. So OHA will pay for up to 6 months of rent, utilities, or house modifications for qualified members. This is a benefit to keep people housed. It's not a benefit for people who are already unhoused. We're only 6 days in, and I believe they said there was 150 applicants already. And currently, there's a 14-day review period. There is an educational webinar on this new benefit on November 19th. This is the first time housing has worked with healthcare, so there's a lot of new things to navigate. We have filled the seat for the Health Policy and Analytics Director, Claire Pierce Global. I did not catch that last part of her name, so don't quote me on that. Will be taking that role. And then also, they wanted to remind everyone that it is open enrollment for 2025, and you can shop and compare plans online. Next, we got into board business, and we really had some really good conversations about our board's priority areas and goals for 2025. We have 4 areas that we are focusing on, one being affordability. And within that, there's 3 goals. One is to create new affordability committee, host public conversation and include that in the conversations, and then also to inform the revision to the HCMO, the Healthcare Market Oversight Committee. Our next priority area is metrics. And with the 3 goals within the metrics is to increase the OHPBO members and add 3 seats on the metrics and scoring committee. Review outcome and quality measures, and move the metrics selection from annually to every 2 years. And so this will help increase the voices heard and provide for deeper participation. Next, we had a great conversation about behavioral health, and it's an ongoing conversation on what goals and what OHPB's role in these goals are to be, whether we're a collaborator, leader, or supporter. We're hoping to be a leader or collaborator in developing the KPIs and hoping to be a continued partner with that. We want to ensure consumer feedback is evident in our strategic goals. And lastly, there was great conversation about OHPB being a leader and possibly creating a new branch of the healthcare or behavioral health committee, because the current behavioral health committee is solely focused on metrics. Like I said, it's an ongoing conversation. Dr. Hemmings, do you have anything else to add to this priority area before I go on to the last one?
No, I don't.
Okay. Like I said, it's an ongoing conversation, and I will update you as we work through this. Our last priority area is the CCO procurement, and the 3 goals are to implement a process to gather information from OHPB members. We would like to have more public input hosting town halls on the contract process, and then receive updates on the procurement process. There was a OHPB and committee kickoff meeting October 29th, and that is online. In our December meeting, we will vote to approve these priority areas and goals. Are there any questions or any comments? All right. With that,
Melina, sorry, Melina, I was just going to
Oh.
make a comment. I did attend the kickoff meeting, and I know there was some feedback around involving the community advisory councils, and I did see the update that came out around involving the CAC. So I was really happy to hear that, because I think of all those are really important voices to have. So I appreciated that.
Wonderful. So with that, I was going to send it back to you, Laura.
Okay. Thank you. I know we do have some OHA written updates that are available to folks in your packet. And I think with that, we'll go ahead and get started with our presentation on the 2025 Healthcare Workforce Needs Assessment presentation. And I'm not sure who's going to go first. We have a number of people here to do that. So
yeah, can you hear me?
We can.
Okay, yeah. Thank you very much for having us today. And we appreciate this opportunity to give a brief update on the Oregon's Healthcare Workforce Needs Assessment Report 2025. My name is Tao Li. I'm Associate Professor of Health Policy at Oregon State University College of Health. Our team has my colleagues, Professor Veronica Irvin and Professor Jeff Luck. Our research assistant is Arlene Barr. In 2017, the Oregon legislature passed House Bill 3261. The bill directs the Oregon Health Policy Board and the Oregon Health Authority to produce an assessment of the healthcare workforce needed to meet needs of patients and community throughout Oregon. The findings from this report are used to inform the use of the Healthcare Provider Incentive Fund and to improve the capacity and diversity of Oregon's healthcare workforce. In today's presentation, we will highlight a few key findings and recommendations. Full report. We use OHA's annotated outline to develop the 2025 report. Main topics include investments in workforce development, healthcare trends and data, healthcare workforce shortages and disparities, healthcare workforce wellness and resiliency. In addition to the overall health analysis and discussions for specific provider types that should be addressed going forward. In this year's report, we developed some new sections, including education and career pathway, school health providers, gender-affirming care providers, and social factors. Our team has been working closely with Oregon Health Authority, advisory group, and subject matter experts to develop this report. The Oregon Healthcare Workforce Committee adopted a strategic framework in May 2023 that defines 3 broad areas requiring attention to make progress towards its vision of healthcare workforce, including workforce development and retention, workforce diversity, and workforce wellness and resiliency. Following the adoption of the framework, the committee organized subcommittees charged with examining data and best practices to publish the strategy papers for these 3 areas in January this year. So we developed our reports in accordance with this framework and papers. Next slide, please. OHA's focus on health equity must include the training, recruitment, and retention of a diverse workforce that can deliver culturally responsive healthcare for all. The Healthcare Workforce Committee developed the equity framework to guide its efforts to center equity in discussion and decision-making. It included recommendations to increase the diversity of the healthcare workforce and to make the workplace more welcoming for diverse providers in various areas. In our report, we will summarize the updated evaluation on the Healthcare Provider Incentive Program. Oregon's Healthcare Provider Incentive Program aimed to build healthcare workforce capacity in rural and medically underserved areas. To achieve these goals, financial incentives are offered to healthcare providers and students in health professional education programs to serve patients in underserved areas. In addition to the Healthcare Provider Incentive Program, Oregon has several other programs that focus on increasing the capacity, retainment, and diversity of the healthcare workforce across a variety of providers. Many programs aim to address current shortages as well as future needs. Some efforts have focused on specific providers. We are working with OHA and our advisory groups to summarize updates of these investments in our report. We will include healthcare workforce reporting program data analysis in our assessment. OHA collect data of healthcare workforce during their license renewal process. These data are an increasingly useful source of reliable information about Oregon's licensed healthcare workforce. We will also include the Area of Unmet Healthcare Need report from the Oregon Office of Rural Health. The report includes community-level data on access to care and healthcare workforce capacity. Next slide, please. We worked with Oregon Primary Care Association to conduct a survey about how the COVID-19 has impacted the workforce. Respondents reported that the pandemic has reshaped the landscape of primary care, emphasizing the well-being of healthcare providers. Healthcare workers are more focused on self-care and work-life balance, recognizing the importance of time and flexibility for personal pursuits. Future Ready Oregon's focus groups of healthcare employers suggested that the healthcare industry is recovering from the COVID pandemic impact, and the full employee life cycle has experienced unprecedented challenges resulting from the pandemic and employee expectations. Current analysis from the Oregon Employment Department shows that there have been consistent increase in healthcare job postings since the pandemic across the state. While many other broad sectors lost jobs, healthcare and social assistance gained more than 15,000 jobs between June 2023 to June 2024. The data further shows job growth across all major areas of the healthcare sector. While there was a strong job growth in healthcare over the past year, nearly 80% of all healthcare vacancies in 2023 were difficult to fill. Over 70% of difficult to fill positions require education beyond high school, compared to nearly 30% of non-difficult to fill positions. Next slide, please. We interviewed healthcare providers to collect their input and summarize the Workforce Development and Retention Subcommittee's strategy paper. Some key recommendations include increased investment in education and training programs to improve skilled and culturally competent healthcare workforce. We recommend developing strategies to increase recruitment, such as increasing access to healthcare careers and improving compensation and social factors. We also recommend developing strategies to increase retention, such as providing wellness support and improving community integration and belonging. The Future Ready Oregon's focus group study discussed challenges to conduct long-term recruitment and demand planning. So we think it will be very important to improve data collection and accessibility to support healthcare employers for demand planning. Next slide, please. The Oregon Employment Department estimates that 50% of jobs in healthcare require some form of post-secondary education. Oregon has invested in supporting education pipelines to attract students into healthcare professions. For example, Northeast Oregon Area Health Education Center provides pathway programs for middle school and high school students. Its MedQuest camp is for high school students to explore careers in the healthcare field. The Tribal Health Scholar Program supports and inspires American Indian and Alaska Native high school students to pursue careers in healthcare. Our recommendations for further improvement in this area include expanding opportunities to support pipeline programs in middle and high schools, increase access to healthcare careers for people from diverse communities, and increase training slots to train more providers, and increase incentives for academic positions. For example, the New York Health Equity Reform 1115 waiver provides career training for participants newly entering the healthcare workforce and for those looking to advance in their careers. The 1115 waiver in New York is estimated to provide about 7,000 slots for nursing workforce and over 3,000 slots for frontline public health workers. In Oregon, House Bill 3396 provides funds to support clinical education at hospital and healthcare facilities. It requires OHA to expand on-the-job training, apprenticeship opportunities, and other programs that support the development of healthcare professionals. Next slide, please. A recent national survey showed that physician burnout rate had dropped below 50% for the first time since the pandemic, compared to over 60% in 2021. Despite this progress, workforce wellness and resiliency remains a critical area as highlighted in the Healthcare Workforce Committee's strategic framework. The Health Resources and Services Administration, or HRSA, conducted the Health Center Workforce Wellbeing Survey to capture baseline data on workforce well-being, job satisfaction, and burnout for health workers. From November 2022 to early February 2023, nearly 700 health centers participated, and more than 52,000 staffs responded to the survey. The survey showed that compensation and benefits was the leading concern that had negative impacts on workforce well-being, with an overall 23% negative responses. For example, about 36% of respondents disagree with the question, "I'm well paid given my training and experience," with 12% of respondents strongly disagree. Next slide, please. The Workforce Wellness and Resiliency Subcommittees recommends strategies to support workforce wellness. We also collect input from the healthcare workforce. As the data just showed, it is important to increase compensation and benefits. Some providers we talked to mentioned that recruiting from rural areas is difficult, exacerbated by the lack of affordable housing and childcare options. So we think it is important to improve social factors to support wellness and resiliency for workforce in rural areas. Provider also told us that Oregon's support for the Oregon Wellness Program provides critical mental health resources for healthcare providers. This support is essential, especially in rural areas where such resources are scarce. Some providers we talked to emphasize the importance of work-life balance to reduce burnout and improve well-being. It is important to create and sustain positive work environment and culture. Healthcare staff are more focused on self-care and work-life balance, recognizing the importance of time and flexibility for personal pursuits. When asked what they saw as the biggest challenges contributing to provider burnout, many respondents to our survey reported high administrative burdens. So it will be important to reduce administrative burdens for healthcare workforce in Oregon. Next slide, please. Now I will pass to my colleague, Professor Jeff Luck, to discuss nursing workforce. Jeff, please.
Thanks, Tom, and good morning, everyone. Oregon has about, or had about 110,000 licensed nurses in 2023, which is about 20% more than in 2020. About 4 in 5 of them are currently practicing. 7 in 10 are registered nurses, and the rest are certified nursing assistants, licensed practical nurses, and nurse practitioners or other advanced practice RNs. So you all have heard about a nursing shortage nationally and in Oregon for years. But in this report, we try to unpack that simple view into some concrete problems that workforce policy can address. And specifically in Oregon, we have insufficient nursing education capacity plus high rates of nurses leaving practice in some clinical settings. On the education side, Oregon universities and community colleges produce the third lowest number of nursing graduates per capita of any state. This is well below the demand for new graduates, so we make up for that with migration from other states. In clinical care, especially hospitals and long-term care facilities, there's what the Oregon Center for Nursing calls a vacancy crisis, which means that licensed nurses are not filling the vacant jobs, even though RNs in Oregon are the third highest paid of any state. There are several reasons for those vacancies, including too many patients per nurse, not feeling safe in the workplace, variable schedules, not being listened to, and all of those contributing to burnout. So OCN summarizes this situation as the leaky bucket that you see in the figure, where the education system can't keep up with the number of nurses leaving clinical positions. So if we assess the situation using that model, a couple policy priorities are clear. First of all, strengthen the nursing education pipeline. Three components of that are expanding the number of clinical placements for student nurses. Second, increasing the number of nurse educators, especially by raising their pay. And then third, expanding classroom and laboratory space to accommodate more students in training programs. The other major policy recommendation is to increase retention of practicing nurses. The state should promote healthy work environments for them. Now, the nurse-to-patient ratios that became effective this July are expected to increase nurse staffing in hospitals and hopefully reduce burnout. But the effects of that policy need to be evaluated to see if it works as intended or has any unintended consequences. And the state should also explore ways to encourage employers to prevent harassment and discrimination, improve communication, and expand collaborative decision-making. There are several successful models for this, such as magnet hospitals. So next slide, please. The long-term care workforce includes home care workers, staff in residential facilities like assisted living and memory care, and CNAs in nursing facilities. So this direct care workforce was hit very hard by COVID and still has not fully recovered. Long-term care facilities in Oregon lost a lot of staff and found it very difficult to fill those positions. This led to discharge delays and long stays at hospitals. The legislature injected a lot of extra funding during the pandemic and appointed a task force to propose solutions to the backups in hospitals. But Oregon's underlying long-term care workforce challenges predate the pandemic. Turnover rates are very high, often 50% or more annually, and employers' vacancy rates are also very high. The biggest reason for this is low pay. Direct care jobs pay less than other entry-level jobs like retail or hospitality, but have higher rates of injury and require more emotional labor. There are also limited opportunities for advancement and pay increases. Direct care workers are also more likely than other healthcare workers to be immigrants, people of color, and have limited education and low incomes, all of which make it harder for them to advocate for better pay and working conditions. And then the facilities that employ direct care workers are constrained by low Medicaid reimbursement rates. All states face these problems, even though in Oregon, direct care workers have better benefits than in most other states, almost any other state, and their pay rates are higher in Oregon than in 40 other states. The fundamental ongoing problem, though, is that Oregon's direct care workforce is not growing as fast as the population is aging. So workforce policy should aim to close that gap. A few recommendations are to raise direct care workers' pay relative to other entry-level jobs. Other states have done that through wage floors or wage pass-throughs of Medicaid reimbursement. Oregon DHS also just completed a rate and wage study that would set higher rates for long-term care facilities to allow them to pay their staff better. So Oregon should evaluate those approaches and select one to implement. Another priority is to expand training and career pathways like the RISE partnership, and another to explore ways to promote healthy work environments for direct care workers, as I described earlier for nurses. Finally, expanding the direct care workforce is going to require collaboration across agencies and stakeholders. So the state should consider establishing a long-term care workforce collaborative or initiative, as have been developed in Washington, Wisconsin, and Colorado. Next slide, please. So pursuant to a letter from the Health Equity Commission, the Policy Board asked OHA to include a section in this year's report on gender-affirming care. And we, in the report, define this term broadly to comprise not just gender transition surgery and hormone therapy, but also the full range of physical, behavioral, and oral healthcare services needed by people who are transgender or gender diverse. And this community includes trans women, trans men, and non-binary or gender non-conforming people. Excuse me. Oregon law mandates that OHP and private insurers cover gender-affirming care, but we know that trans people still face many barriers to care, especially shortages of trained providers and often clinical environments that are not welcoming. Trans people also have higher needs for care, especially behavioral health and social determinants like secure housing. We don't know exactly how many trans Oregonians there are, but it's certainly tens of thousands of adolescents and adults. And the higher proportion of trans people in younger age groups tells us that demand for gender-affirming care will continue to grow faster than the state's population. There are some clinical standards of gender-affirming care, but because they're not required in medical or nursing school or other clinical training programs, many providers are not adequately trained to treat trans patients. That also means we have very limited data on the adequacy of the gender-affirming care workforce. Excuse me. Anecdotally, we know that in Oregon, gender-affirming care is most accessible in the Portland area, more limited in other cities, and can be very hard to find in rural areas. Other shortages are specific to gender-affirming providers. For example, there are far too few electrologists to serve the needs of the number of Oregonians who want to undergo gender transition surgery. So this initial picture is not nearly as clear as for other segments of the workforce that you'll hear about. But a few policy priorities do emerge, which were also outlined by the Health Equity Committee in its letter. First is to train more providers and the staff at their organizations to treat trans patients. OHSU has some great training programs, but they don't come close to meeting the need. Second, measure the state's trans population to estimate the demand for gender-affirming care, and also measure the supply of competent providers. So on the patient side, the SOGI data collected by OHA are a good start, but to measure provider adequacy, OHE will need to develop new measures of clinical competence and organizational inclusivity. And finally, the state should explore options to expand the number of gender-affirming care specialists like electrologists and surgeons. Next slide, please. And then just to speak briefly about telehealth, telehealth includes many different modalities by which patients interact remotely with providers, including audio calls, video conferencing, and remote monitoring. Telehealth has the potential to broaden urban access to specialty care or to any providers in rural areas. And it can either reduce or widen disparities in access. The figure shows that telehealth utilization spiked up dramatically in 2020, then dropped off as the pandemic waned. Telehealth use still remains much higher than it was before the pandemic, though, but about 2/3 of it is now for behavioral health. Oregon expanded insurance coverage of telehealth during the pandemic, and those regulations are now permanent. Federal policy flexibilities currently end after December, but hopefully will soon be extended for another 2 years. OHP provided data from fiscal year 2023 showing that all racial ethnic groups had similar access to telehealth within OHP, but that rural and frontier members were much less likely to use telehealth even than urban residents, even though they should be able to benefit from it the most. So that concludes my section, and we've set aside a few minutes here before Professor Irvin speaks about the rest of the report to talk about for questions. And so we'd like to give about 5 minutes or so for committee members the chance to ask some initial questions.
So committee members, if you want to raise your hand or just go ahead and come off mute, please feel free.
I do not see any questions so far.
This is Jason. I did have a question. So, would you mind going back to the pipeline slides, the education ones? Thank you. I wanted to see if part of the research and the report is about maybe what other states are doing well, that maybe, or ideas that are emerged in other places that we might want to consider.
Thank you very much for your question. In the full report, we did discuss some examples from other states and also at the national level. And like I mentioned in the presentation, like we talk about the New York Health Equity Reform, the 1115 waivers, and we have some more details about how the 1115 waiver in New York to support the education and the training programs there. And at the national level, we also talk about some national level programs to support residency training to increase the primary care physician residency training, for example, in the full report. Thank you.
Thank you.
Yep. And I would also like to mention that, Professor Jeff Luck just mentioned, in different other sections for specific provider types, we also discuss some examples from other states, like, for example, the nursing workforce. Jeff, do you want to add some comments here? Thank you, Jeff.
No, that's a good summary. Thanks, Tom.
Hello, this is Dr. Hammonds. I don't see my raised hand, so my apologies. Regarding the telehealth, could we go back to that slide? I think I heard you say that even though telehealth is available, that there is a disparity in rural communities in terms of utilizing telehealth. Was that correct?
It appears to be the proportion of OHP visits that are provided, the proportion of OHP outpatient visits that are provided by telehealth is significantly lower in rural areas than in urban areas, which is
Go ahead.
I say it's a little bit surprising, but that's
Do we have any ideas as to why that is? Is it on the provider side or is it on the patient side that the issue might be?
That's a great question. I from the information that we've been able to find, we don't have an answer to that, but I think that's you're asking exactly the important question.
And we don't know whether or not this is because, patients often will be given an option, right, of a virtual visit versus an in-person visit. So I'm wondering, is this a situation where patients are opting not to do virtual and would prefer to be in person? Or is it that virtual is not necessarily being offered? Is there something about that demographics that makes virtual visits not appropriate? There's so many nuances, right, that could be contributing to this, but I find that to be very interesting because, one of the things with telehealth is we're actually thinking that it's going to actually increase and enhance access to care. But that's not what's happening, especially in the communities that need it the most. And yeah, also bandwidth, right?
Right.
That's why I want to know if it's on the patient side or is it on the provider side, and access to internet services, things like that.
Right. I think those are will be good questions to investigate, but we haven't.
Yeah, and this is Laura. I think that's
too.
interesting. I think of areas like Curry County, Southern Oregon coast, where
provider availability is very slim, and virtual is sometimes the only option for those members there. So I'd be curious to see. I know they're getting in broadband is coming into Curry, thank goodness. So they'll have a lot more options as far as that goes. But I think that's an interesting line there that I'm seeing for telehealth.
Right. So, and I think we probably have time for one or maybe two more questions. And then, to give Professor Urban enough time to stay on schedule. So I see Manu Chowdhury, please.
Yeah, thank you so much. Very informative. Always appreciate learning about these things. I see that the slide largely references primary specialty in behavioral health care. Being an oral health representative, would you be able to speak to telehealth access, specifically for oral health, and then displayed, by different areas of Oregon?
We were not able to get data on specialty on the specialty care breakdown for telehealth this year. I do know that when we got that breakdown for the last report, the number of oral telehealth visits was extremely small. So that's and in my other reading of a telehealth, I found that oral health is the domain of healthcare which probably has the lowest utilization of telehealth.
That's very helpful. And just one more quick follow-up question. What other healthcare systems are included under the specialty umbrella in addition to oral health?
Well, I think that, I guess I'm usually thinking about, medical and surgical specialties when I'm using that term.
Okay, thank you.
The medical and surgical physical health specialties. And then, so Ian Strauss, I also see.
Okay, thank you. Again, thank you for some really great information. I'm curious, in discussing the nursing workforce, we've seen some changes to the required length of education for RNs in the state and other pathways pieces. Is there any information on what is going to be required in terms of pathway programs moving from, say, LPNs to RNs, the RN to NP programs, things that can allow us to use our existing workforce and make that more effective in terms of filling these higher license level requirements?
I saw some references to those, but haven't delved into them in detail. So that's something I can look into as we revise the report.
Thank you.
Sure. And then, Laura, do we have time for one more question, or should we? What do you think we should do?
We could do one more quick question, sure.
Okay.
Laura, did you see Melina had asked a question in the chat?
Hi, I'll come off mute. Yeah, I was just wondering about including international medical providers to aid in the shortage. Was this considered, or any data on that?
Question.
Jeff or Veronica, do you have any data on the international providers for any specific provider types?
Not that's not something I've investigated.
Yeah.
I don't have anything specific that I can cite. In some conversations in a section on healthcare interpreters, there is some thought about our interpreters being Are they coming from the certified registry here in Oregon, or are they coming from outside Oregon or outside the country? I don't have data on those pieces, but that has been a question that was raised.
Yeah.
And is that and there's really no been an evaluation around that piece. That's the only one off the top of my head that I can think of. There was some discussion around that occurring.
Committee members, any more quick questions before we move on?
I was just curious if there are any insights about education pipelines to address the direct care workforce vacancies. I know that you talked about the education pipelines in the context of nurses, and didn't know if there was any lessons for or targeted interventions for pipelines for direct care, or
There are, in fact, like the RISE partnership is, for example, funding stipends and apprenticeships for CNAs, and there's some other pipeline projects, or I would say pathway projects or initiatives that are being funded in Oregon. There's also some that are happening in other states. There's like a CNA to LPN pathway in Washington State that's pretty highly regarded. So I didn't have chance to talk about it today, but there are efforts underway in Oregon, but they could be expanded. There are more, there certainly are more direct care workers who could benefit from the opportunity to enter into those pathways.
And I'll just briefly comment which I have not presented on yet, but in the oral health section, there is a committee reviewing recommendations around pathways around the dental assistant workforce shortage and looking at new pathways to improve shorten the time and improve the number that enroll. Would you like me to begin with my next section? We have time at the end for another set of questions as well. We just kind of wanted to break up our presentation. And if you could start at the traditional health worker section. Thank you so much. I believe that's my first set of slides. And so we will have myself and Dr. Lee will present again for probably 15, 20 minutes, and then have time for more questions, hopefully.
Great. Thanks, Veronica.
Great. So I am presenting, my first section I'll be talking about is the traditional health worker section. On this slide, you'll see a snapshot from October about the different types of providers broken down as registered as of October of this year. There are currently over 6,500 traditional health workers registered and over 7,600 certifications. So some individuals have dual certifications, and that number has doubled since our previous report. You'll see about 20% are community health workers, 30% are peer support specialists in adult addictions, 18% are peer support specialists in mental health, and there are fewer registered traditional health workers serving our youth. A survey done a few years ago interviewed and surveyed members from our communities of color, and they recommended seeing an increase in traditional health workers that serve their organizations, and in fact, having more traditional health workers coming from community-based organizations. Some key recommendations that have been coming out of the Traditional Health Worker Commission has been plans to expand the registry into Spanish language. They are looking at holding more trainings for the traditional health workers outside the Portland metro area. So right now there's a lot of trainings for community health workers and the peer support specialists and wellness specialists, with a lot being held in the Portland metro area and looking to expand those statewide. There are options for these trainings to be held remotely or virtually. They are also considering different testing, different payment models from the CCOs. There was a presentation a few months ago to this organization or to the commission about some different models that they like to test that different CCOs are implementing about the payment for traditional health workers. And there is concern again of increasing compensation for the traditional health workers. And there's focusing on, again, not only compensation, but retention. So flexibility in the types of hours they can work, more support around onboarding and really focusing on self-care of the traditional health worker. There is also a policy option package that's being worked on to expand the doula section of the traditional health worker providers. Next slide, please. Next, we'll briefly talk about healthcare interpreters. Since the passage of House Bill 2359, the number of credentialed healthcare interpreters have tripled. We now have over 2,200 qualified and certified interpreters on the Oregon registry. We see that the diffusion of language, or the amount of different types of languages that services are provided in, has increased to over 50 different languages. The most common language spoken by the interpreter is Spanish, with over half of the registered interpreters indicating Spanish language, and about 15% indicating using American Sign Language. From some of the recommendations, we're seeing continue to invest in expanding the free training. So right now, the certification and trainings are free, and that has really reduced the barriers to the certification process. So looking to maintain that, looking to invest or expand in opportunities to better reach healthcare interpreters working in rural communities. The other is improving compensation. And here we mentioned like publicizing the registry, making it easier for individuals to access the registry, work through the registry. There's also some consideration about evaluating what percent of the CCOs are using healthcare interpreters off of the registry, and what that compensation looks like. What is the healthcare interpreter actually being paid, and how that may differ if it's being done through a language service company or if the healthcare interpreter is hired as an individual contractor. There's also requests to provide additional technical assistance for providers and the healthcare systems to improve their language access plans, for forecasting the needs, and for evaluating and auditing the reports. Next slide, please. Behavioral health. As you probably know, there has been substantial investment in the behavioral health providers here in Oregon. And there's also been quite a number of evaluations on some of the behavioral health and substance use provider programs. What we'll note is that OHA, of the substantial investment put into the behavioral workforce investment, OHA has successfully allocated 98% of those funds from the Behavioral Workforce Initiative. Funding from that initiative went to 9 federally recognized tribes in Oregon to increase the behavioral health services, and 5 scholarship grants were awarded to higher education and community-based programs to increase individuals pursuing education in behavioral health. On this slide, we show the FTE by county per 1,000 population of the licensed behavioral providers. And the next slide, I'll talk about the unlicensed but certified workforce. And what we see here is that since our last report in 2023, we have seen an increase in the overall FTE of the behavioral health provider workforce here in Oregon. It has increased in the last 2 years. We are still seeing shortages in the rural areas and shortages around providers of color. What I'd also like to say is we also are still seeing a gap in providers who serve children. And so we see an increase in the amount of providers serving the adult community, but fewer increases in those serving the children. For the substance use treatment, we're also seeing an ask to try and do dual certification, so that in some of the facilities you can have staff certified for both substance use treatment and co-occurring mental health disorders. I don't want to move slides yet, but in a moment on the next slides, I'll be talking a little bit about the unlicensed workforce. There have been a number of recommendations coming out in the last few years, in the last 2 years. And so I summarize just a few on here, but of course, higher pay. So there is still a considerable pay gap among even the licensed healthcare workers compared to other healthcare sector jobs and other types of employment outside the healthcare sector, making it difficult to recruit and retain. So really looking at increasing the wage floors and parity with other sectors. Really looking at increasing reimbursement rates, possibly increasing for complexity of the patient dynamics that they're working with, increasing reciprocity with other states, as well as there has been quite a few incentive programs that I believe another speaker later in today's meeting will be discussing some of those. So we have seen an increase in those sections. We are also looking with more partnerships with community-based organizations. There has been some call from some of the community groups to increase the delivery of some of the behavioral health and substance use disorders from peers and or from members of community-based organizations or faith-based organizations. I'd like to move to the next slide for a moment. And I just briefly touching on the certified but not licensed. So starting in this year's report, there's going to be expanded data for the mental health professionals that are certified but not licensed. And there's several provider types. Today, I'm just going to show 2 examples, but there's going to be several that are going to be now reported that OHA has access to on the numbers, and comparing them to the number of availability in each county adjusted for population size. So if we look at this slide, this is for the certified alcohol and drug counselors. The blue bars represent the number of certified and drug counselors per 1,000 population within each county. And the orange bar indicates the state average, which is about 1.2 certified alcohol and drug counselors per 1,000 individuals. And we can see, again, differences within counties. If we could go to the next slide, please. Here we show an example from the same type of graph, but reporting the qualified mental health associates. There will also be a graph for the qualified mental health professionals. Again, looking at by county, the number of qualified mental health associates per 1,000 people in that county. And then the orange bar indicates the state average. And again, about 1.23. The other types of providers that will be discussed are certified recovery mentors, certified gambling addiction counselors, certified prevention specialists, and qualified mental health professionals. Again, this slide shows qualified mental health associates. Next slide, please. Thank you. Since last month, Oregon is still considered a designated health care provider shortage among oral health providers. We see that the direct patient care and the license of dentists and dental hygienists has been pretty much stable since our last report. We still see differences or lower numbers of providers by population size in the rural and remote areas. There has been significant grant initiatives that have been done through Oregon Health Authority, and again, I believe there's some presentations later today. Those are including extension of the ECHO, which is the Extension for Community Healthcare Outcomes, which is a knowledge sharing network to provide training and cohort building across counties. Expansion of a mobile van to additional sites that has showed decreased no-show rates. And subsidizing a new dental clinic in Brookings. We also see for most of the CCOs, many of them have achieved the benchmarks for preventative dental health services and services for adults with diabetes in the 2023 report of CCOs. There was a House bill passed in 2023, House Bill 3223. And it was asked, and they have asked the Oregon Board of Dentistry to convene an advisory committee to study the dental assistant workforce shortage and make recommendations to address these shortages. Some of our recommendations come from this report. And mentioning back to your previous question, one of the questions or suggestions is the pipeline for the dental assistants. The draft reports are available. We'll be citing them, but they're continuing to be discussed. There has been an increased number of participants in the loan repayment program, and to date, 62 dentists and 21 expanded practice dental hygienists in Oregon have participated in these loan repayment program. Let me get my lights to come back on for just a moment. Some key recommendations are to increase and diversify the oral health workforce, again, focusing on the needs in the rural communities, continuing to invest in the loan repayment programs and shortages, increasing the reimbursement for providers who serve publicly insured patients, and expanding the reach through school-based programs, mobile vans, teledentistry. Next slide, please. Public health. Since our last report, there has not been a lot new data been collected, but there are a lot of subcommittee work being done on recommendations from the previous report. One report that came out was the impact of the public health modernization funding. And the evaluation report has shown with the increased funding in the 2021 to 2023 biennium, there was an increase in more than 300 positions, either partly funded or fully funded, with some of their funding coming from public health workforce, public health modernization, pardon me. There is some concerns as some of the COVID funding is going away for additional loss of staff. That yet has been vocalized, but there is no report yet showing that. Since the previous report that we conducted, there is a specific public health workforce needs assessment being conducted. There is currently a capacity and cost assessment being finalized in the next month or two, and more survey data from our state and county partners. And so some of the key recommendations that the work group is currently prioritizing some recommendations, and those should be finalized in January from the public health workforce group in our state. But as Dr. Lee had mentioned, really resolving some administrative barriers on hiring and retention, increasing compensation, reimbursing for education, and being added to some of the loan repayment programs, and ways to actually retain and keep staff in the rural areas. Next slide, my last slide, please. New report this year, a new section that was asked of us this year is on the social factors. And we would really appreciate feedback on the direction on this. We took this to mean social factors around transportation, childcare, and housing. And there's been a lot of work done around supporting the transportation, childcare, and housing needs of our patients and clients, but not a lot directly supporting the workforce. So there has been some work about offering transportation subsidies, offering childcare subsidies or on-site, and really focusing on housing shortages. And one of the best program I have seen so far is actually done through our Behavioral Workforce Incentive Program, where they're offering housing stipends and incentives, and 20 organizations, out of about 80 organizations applied, and 20 organizations received funding to offer sign-on bonuses, including housing stipends. And we have seen some organizations starting to purchase housing for some of their frontline workers, which may include some of the healthcare providers. Dr. Lee, I'll pass it to you.
Thank you, Veronica. Next slide, please. The 2024 Licensed Healthcare Workforce Supply Report by OHA estimated there were over 9,500 primary care providers actively practicing in Oregon, compared to around 8,900 in 2022. The direct patient care FTE for primary care professional to population ratios at state level was 17 FTE per 10,000 Oregonians. The county level ratio vary widely, ranging from 4.6 per 10,000 at Sherman County to 34.6 per 10,000 at Wallowa County. The 2024 primary care scorecard showed that Oregon is the highest ranked state for primary care spending. In 2021, 7.7% of total healthcare spending in Oregon was invested in primary care, compared to 4.7% nationally. In 2023, Oregon legislative passed Senate Bill 490 to provide funding support for the Oregon Residency Collaborative Alliance for Family Medicine. It provides residents with networking and collaboration opportunities for professional development, and also supports faculty development in primary care. In Oregon, the legislature created the primary care, the patient-centered primary care home, or PCPCH program, as part of a comprehensive statewide strategy for health system transformation. Beginning January 2025, there were 36 PCPCH standards under the revised recognition criteria. In our report, we included a few new recognition criteria that is closely linked to primary care workforce. So, for example, the new recognition criteria highlight value-based payment standard to enable primary care providers to move toward advanced value-based payment arrangements. This is also similar to the New York Health Equity Reform 1115 waivers, have like similar support in New York. We will have more details in our full report. The 2025 PCPCH recognition criteria will also require practices to assure their staff is trained in delivering culturally and linguistically appropriate care. This aligns with OHA's goal of eliminating health inequities in the state. Next slide, please. In this year's report, we added a new section of school health providers. We have worked very closely with Oregon Department of Education and subject matter experts to develop this new section of school health providers. As shown by the table at the top, school nurse FTE increased from 279 in 2017 to 18 school year to about 408 FTE in 2023 to 2024 school year. Despite this increasing nurse FTE, student health needs still exceed the capacity of available school nurses and LPNs in most school districts. For example, in school year 2023 to 2024, the statewide school nurse to student ratio is almost 3 times higher than the recommended ratio, with only 19 school districts, or about 10%, meeting this recommended ratio. Oregon Department of Education recently conducted a study on school-based occupational therapist, physical therapist, and speech-language pathology therapist. The study found that more than 60% of these practitioners serve over 50 students with individualized education programs and Section 504 plans. Over 80% of licensed practitioners responded that their high workload impacted their ability to provide services to students. Next slide, please. This table shows school mental health professionals to student ratio in Oregon schools. We can see that the statewide ratio of school mental health professionals to student is well below the recommended ratio for each provider type. So in general, Oregon schools are experiencing significant staffing shortages. Oregon Department of Education recommends establishing a transparent and evidence-based workload methodology to help with recruitment and retention of school health providers. Oregon Department of Education and partners at the OHA and Oregon Department of Human Services are implementing several innovative strategies to scaffold the mental health workforce, which we discuss in the full report. Next slide, please. In conclusion, Oregon has made progress in expanding, retaining, and diversifying the healthcare workforce since the release of our 2023 report. Our current assessment report provides recommendations on achieving the Healthcare Workforce Committee's vision of a robust, diverse, and resilient healthcare workforce that provides culturally and linguistically responsive care, eliminates health inequities, and meets the local healthcare needs of everyone in Oregon. The report's recommendations are interrelated and warrant collaborative and coordinated actions among government, legislature, education institutions, healthcare organizations, and local communities to ensure Oregon has the workforce it needs. Next slide, please. Again, we would like to thank OHA, the Project Advisory Group, Workforce Committee, and content experts for all their support to our work. Specifically, we have regular meetings with Neelam, Rebecca, and Dipti for this project. We would like to especially thank them for all their support and help and advice. Thank you all again for having us today, and we appreciate your comments, feedback, and questions.
Hi there. Oh, sorry.
Oh, that's okay. I was just going to say thank you, Tao, Veronica, Jeff, and Arlene. Committee members, we do have a few minutes for questions, comments, and I will go ahead and turn it over to you. I think that was Rob. Was that you?
That was me. I'm just curious about the slides you have on the behavioral health workforce. It was near the beginning of the presentation. You don't have to go there. My question is, you're measuring licensed practitioners of behavioral health. Do you go beyond that? Because my question is, out of those licensed behavioral health providers, what percentage actually take Medicare and Medicaid? Because that's the issue in Deschutes County. We may have plenty of behavioral health according to the population. However, a lot of them are in private practice and they do not take any governmental insurance, TRICARE, Medicaid, Medicare. And do you guys go beyond that and ask if the providers are accepting any of those payment methods?
I will definitely look up that response. We have that in some of our sections about what % of the workforce, of the licensed workforce, takes the Medicare and Medicaid payments. I don't have that off the top of my head, but I will include that. And we have expanded, I would say OHA has expanded the unlicensed but certified workforce, and we will have several slides about those. But I will make sure that we add a note in about % that take OHP or Medicaid and Medicaid services. Thank you for that question.
Ian, I think you were next.
Okay. So question about the integration of primary care and behavioral health. We've seen in the PCPCH standards that there's a push to integrating behavioral health into primary care, but at least when I was running a clinic, we ran into a lot of roadblocks in terms of being able to, both staffing and payment for making those programs successful. So I'm curious if there's anything in the research that you're doing and the report that looks at that integration and ways to streamline that process.
I will just say that there's a list of recommendations that have been coming out from these evaluations, and that is one of them on establishing coordination, not only between the mental health and substance use providers, but between primary care coordination as well. I don't have an answer beyond that is been requested as a need to further investigate how to better do that. But I would definitely if you have any suggestions for me, I'm glad to connect with you after the meeting.
Sure, I'm certainly willing to discuss that.
Sure.
And I can't see everyone, but Manu, I see your hand up.
Great, thank you very much. I have 3 comments, and the first one is just as way of an introduction. I have the privilege to serve as president of Capital Dental Care. We contract, we're a Medicaid OHP only dental organization. We contract with about 475 dental providers throughout the state in order to provide care for the OHP population. While I don't have data at my fingertips, through a few different meetings, we've been able to ascertain, particularly around scheduling with certified and qualified healthcare interpreters, is generally out longer than it is for a non-qualified or certified healthcare interpreter, as much as a few months. And so when we're trying to combat the extreme components of dental disease and dental care that needs to be done, we're really kind of at a loss for trying to prevent or trying to treat the dental disease with trying to make do with the requirements of having certified and qualified healthcare interpreters to provide care. The second comment that I want to make is around the oral health slide. Very informative. Thank you very much to express and identify all of the different puzzle pieces that OHA and the leadership of the healthcare workforce department to really kind of put down and lay the groundwork for the future. I do want to highlight that while we currently contract with 475, that number was significantly greater pre-COVID. In addition to that, there has been a significant lowered reimbursement of up to 25% between 2020 and 2025. And so I would like to kind of turn it over to you before I then ask my third question is, fully knowing that for the last 5 years, there's been a reduction in OHP reimbursement, a reduction in the number of OHP dental providers, such to the point that OHA actually shared back in May in front of a legislative committee that 12% of the dentists perform care for the majority of care for 34% of our population. And so through your review and assessment, particularly around oral health, have you been able to identify any other nuggets that we can kind of steer the elephant into really ensuring that every Oregonian has equal access to care?
Thank you very much for that. What I would say, I did not mention on the OHP for oral health, a recent evaluation came out, and there's been some recent presentations that you mentioned that only half of the organ dentists, half don't take OHP. And again, like you said, there's concerns about the reimbursement rates, and there's a series of recommendations on reducing the administrative error and increasing the cost, where they basically say that they're unable to be in the black at all for any funding except for preventative screening, but in not that the reimbursement rates for providers of OHP patients is drastically low, and looking to ways to increase that. I would like to follow up with you on a couple of your other points to add some of those data into this report. And did you have a third comment?
Going back to the oral health piece, and I believe this was actually published by OHA back in May, it said 82% of the Oregon dentists do not accept OHP as a OHP dental. So while, to me, that is a far more impactful number than the lower numbers that we had shared before. The last question or comment that I wanted to make was around the PCPH model that was presented. I vaguely recall there's about 600, maybe 630 PCH organizations throughout the state. And I realize that there's essentially 5 different tiers. While we are a more, our system, healthcare system is different, and what I would, in my opinion, more advanced than the rest of the country. And, of these 600 PCPH, how many of them have an integrated system where it has behavioral health providers and oral health providers as a part of the care system within that model or within that organization? Would you be able to share that level of information?
I will have to double check if we have that access. The PCP, I will double check on that. At this point, I do not have that data in the report on the behavioral health, but I will double check with my experts if we can add that in.
Okay, and also including behavioral health and oral health with those providers contained within the PCH model. Thank you. Appreciate it.
Yeah.
Thank you, Dr. Chaudhry. And I just had one quick question. And I know we're running up against break time, but did you happen to analyze and or review the data by region for the certified and qualified interpreters?
We have that. It's a little, so it's not as clean because of the way it's reported, but it is something that I can check with my expert if we can maybe make some broader analysis that we can report on that report. I can double check on that. Okay,
Thank you,
great.
Veronica.
Yeah.
Looks like you're muted, Laura. All right, I see you talking.
Thanks, Tim. Sorry. I was just going to say, I know we're at break time. I want to be just respectful of the rest of the content that we need to get through. So we will go ahead and take a 10-minute break. And we'll be back here about 11:10, and we will continue with our presentation. And I think we'll go ahead and get started. Jessica, can you go to the next slide, please? Okay. Now we are going to have our presentation on House Bill 2235. This is the behavioral health workforce presentation by the work group. Next slide, Jessica. And let's go to the next slide. Okay. And I'm not quite sure who's taking the lead on this, but I will let whoever it is go ahead and kick us off.
Yeah, thank you, Laura, and thank you for the committee for having us here today. I'm Tim Nesbitt. He's pronounced like he, him, his, and I am the Behavioral Health Workforce Incentives Manager for the incentives team here at the Behavioral Health Division at OHA. Again, very happy to be here and really appreciate all of the presentations so far. OSU, you did a great job, and nice to see some of our programs got mentioned in there. So great. So we won't be talking about our programs though today. We will be talking about our work group that we convene. So I will go ahead and introduce my co-facilitator, Jen Allen. And I'll let Jen, well, actually, I'll let Jen introduce herself, and then I'll let Jen take it away on this slide.
Thanks, Tim. Hey, everyone. Nice to be here. Jen Allen, she, her, hers pronouns. I am the community and advisory group coordinator. Sorry, I'm a little delayed. It's a new position to me, so I'm still getting used to saying that. Also the project manager for this work group. And with that, we're just gonna go through our presentation, and then hopefully we'll have some time for questions later. Oh wait, no. Can we go back one slide? So I'm assuming everyone can read this, but I'm also going to assume that it might be better to read it to you. So we're just going to blow through these. Thank you. House Bill 2235 was signed in 2023 and charges OHA with convening a 21-member work group to study and provide recommendations on major barriers to recruitment and retention of the publicly financed behavioral health system. These recommendations will inform two reports, first due in January 25, the second in December 25. The first report will inform legislators on what resources to commit to OHA's budget, while the second report will inform broader legislative actions, in other words, reimbursement rates, potentially licensure boards, things like that. The work group members were recruited in December of 23 and are one of the most diverse work groups that OHA has ever convened. Next slide.
Yeah, thanks, Jen, and thanks for that background. Yeah, we thought it would be good to sort of provide you all with some idea of like the framework of how this work group has been really, looking through all these huge topics which have to do with behavioral health workforce. And as Jen was stating, it's a limited duration work group, so we don't have a permanent placement for the work group and like unlimited time and anything like that. So yeah, we had to figure out some way to get all of this together and to formulate our discussion. So in the initial meetings, we did a lot of things like creating a work group charter, establishing the schedule, and then identifying our priority topics. So we use the House bill itself as a guide because it actually does mention quite a few topics that should be considered within the work group. And from there, we went to the work group and we said, here's what it says in the House bill. Now, let's talk about how we can go through this. So what we identified were three main topics of workforce development: behavioral health workforce development, behavioral health workforce recruitment, behavioral health workforce retention. And with a focus on the publicly financed behavioral health services. So from there, we identified these 5 subtopics. So diversifying the behavioral health workforce, reimbursement and pay, workload reduction, administrative burden, burnout, compassion fatigue, and vicarious trauma. So the way that we framed this was actually looking at what we did is we looked at a lot of our subtopics through the lens of the main topics. So in other words, what we did was, like, for example, if we take diversifying the workforce, we would look at what retention issues are faced when diversifying the workforce, what recruitment issues are faced when diversifying the workforce, what workforce development pathways are lacking when diversifying the behavioral health workforce. And so we did that for each one of these and moving forward. And that's what we'll continue to do as we get to the appropriate reports for each of these topics. Let's go to the next slide. Okay, so we gave you a bit of an idea of how the framework has worked and how we've conducted kind of wrapping our heads around this huge issue that we face. And so now we'll get to where we're at currently. So the work group is still refining recommendations, has worked to pass 19 recommendations to be on the report. And those 19 recommendations we've provided on the slides that we'll get into a little bit later. To assist with identifying and really fleshing out a lot of these recommendations, we've designed special work sessions that are outside of the public meetings to allow for work group members to have more time to discuss, wordsmith, and just ask questions to each other and discuss, what the intent around their recommendations is and sort of where they're coming from. As Jen mentioned before, we have a very diverse group of members in the work group. So that's not only in sort of the sense of race and ethnicity and language, but also in the sense of just different parts of the work sector, because behavioral health is just so broad. So those sessions were very key into getting to some agreements within those recommendations. So the next steps are for the work group to finish voting on recommendations. We have 4 to 5 recommendations that still need to be discussed, and we're actually having our public meeting today to hopefully get through those. And to further prioritize all the past recommendations. So we have a form that we have had our work group members, we've asked them to complete, and we'll be discussing the results of those forms where they were able to prioritize out of all the recommendations that have been voted on so far. Okay, we left a link here for our webpage, which actually has all the invites to our public meetings, which occur on the 1st and 3rd Wednesday of every month. And also has all the recordings from past meetings and all the meeting minutes and all those fun things that come with public meetings. Yeah, let's go to the next slide. All right, and I'll pass it back over to Jen to talk about our timeline.
Thank you, Tim. Okay, so this is the report timeline just for the work group. So the 6th, it says we have the final recommendation votes where we will hopefully get the last few recommendations that we can then provide to our contract report writers to go ahead and inform their executive summary and then framework for the report itself. We will also be, as Tim mentioned, reviewing the prioritizations that they did. And the reason we did that is because there are so many, we wanted to make sure that the work group members' voices were heard in this report, since that's what the House bill asked for, was for their words, their thoughts. We're just kind of the vehicle to get that done. On the 20th, we will be reviewing the outline and executive summary. And then on the 4th of December, we will be reviewing the draft report, which is really exciting. We will be using the new guidelines that OHA has established for reporting. It mainly just sets up a timeline to make sure that everyone has time to review it, to make sure that things don't fall through the cracks and that OHA is unified in the reports that they produce. And then we have the final report and presentation that will be provided from our report writers to the work group on the 18th. And then that's when leadership gets involved and starts to review, and it goes up the chain until we're ready to send it off to legislation. And we're really excited for this. Okay, next slide.
Oh, you got muted, Jen.
Sorry, thank you. So we're just going to go right into the recommendations that have been voted on by the work group to be included in the report. I just want you to keep in mind that this is not the final language that will be in the report. These are their words that they've created. We will also be our report writers will also provide applicable lit review, historical data, maybe some findings of what's been done in other states. We may have implementation suggestions as well for some of these. Some of these programs we are already doing in the behavioral health workforce incentives team. Some of these would be brand new. And again, these are only for legislature funding for OHA programs. So the first one is modify the existing clinical supervision expansion grant to include mentoring new clinicians and cohorts of clinicians pursuing licensure in the funding guidelines. This would work by allowing grant recipients to prioritize contracting with pre-existing supervisors in the Oregon community that have an established business or model. Fund regional behavioral health consortiums across Oregon that provide membership of publicly funded behavioral health providers and community-based organizations, including organizations that provide culturally and linguistically specific services. Next, we have OHA to adopt a program evaluation process of BH workforce incentive programs with outcomes that are publicized regularly. This process is to use the least number of state resources as possible and is not to exceed 1% of a grant program source budget. The measuring of administrative burden on incentive program applicants and recipients is to be a component of each evaluation. We felt this one was really important. We don't have enough measures of outcomes in place, and we would like to be able to know how we're doing, if what we're doing is working, if it needs to be done differently. It's really to have the input of experts come in and, grade the process. Next up is change the narrative of community mental health programs as preferred workplace options by investing in a state-led marketing, promotion, and community engagement. Then we have OHA funding for psychological and physical safety needs improvements, equipment, and training for behavioral health staff. Finally, on this page, invest in career and technical education, behavioral health pathway for Oregon high school students. Next slide, please.
Yeah, thanks, Jen. I'll take this next one. We've got a lot of recommendations, so we thought we'd trade off so we don't lose our voices. The next one is a new, not existing, in other words, not existing behavioral health workforce incentive program that incentivizes trained providers in acute care settings. For example, behavioral health inpatient facilities/units that focuses on increasing pay, increasing safety and employee wellness, and that prioritizes providers who are culturally specific, linguistically specific, and providers who are a part of communities that have been economically and socially marginalized. Raise and maintain the maximum allowance for administrative expenses in behavioral health workforce incentive programs to 12 to 15%, This increase will help cover costs associated with meeting the program's requirements and reporting obligations. Next is adjust existing behavioral health workforce incentive programs that support behavioral health training programs at community colleges, technical colleges, apprenticeships, and other community-based organizations. So then it gives a few examples there. To be zero cost, include funding for administrative support of apprenticeships and education. Next is a program that would provide elective training, so 40 hours per employee paid time off for career development, educational pursuits. Funding stream for clinical supervisors to provide clinical supervision for licensure and certification. And then we did find that that was very much supportive of our existing clinical supervision expansion grant. So that, as Jen was saying, this isn't the final text that will be used. So it would probably read something like to support the existing clinical supervision program, for example. And then last on this page is funding for professional development or career paths of culturally specific, linguistically specific, certified, registered to be certified, and peer behavioral health providers. And next slide.
Childcare and housing stipends as part of a grant to CMHP's Certificate of Approval Organizations, community-based organizations that provide behavioral health and culturally specific and or linguistically specific behavioral health provider organizations, OHA designated or otherwise, as money upfront for childcare and housing. Create a grant program for retention strategies for all client-facing staff at community mental health programs and Certificate of Approval organizations. Ongoing funding for community mental health programs, Certificate of Approval organizations, community-based organizations, and rural organizations to provide tuition assistance for employees pursuing degrees or certifications, prioritizing master's level degrees in behavioral health related to work or future work at their organizations. Provide funding for graduate assistants to assist with costs of behavioral health education, internships at CMHPs, and other COA organizations, behavioral health license certification prep and exams, and other costs. Funding for organizations to propose paid internship programs, including pre-credential, internship staff management, internship administrative costs, and clinical supervision for rural community-based organizations, Certificate of Approval organizations, and community health, mental health programs. Next slide, please.
All right. Thank you. And these two states, OHA should use funding set asides and prioritization within all behavioral health workforce incentive programs, including loan forgiveness, stipends for continuing education, scholarships for higher education relevant fields, and bonuses for those who commit to working in underserved areas to attract and retain individuals in peer services, culturally specific, linguistically specific, and OHA designated culturally and linguistically specific service roles. This approach helps mitigate disparities and supports workforce development. And the last one is a portion of OHA's budget should be dedicated to initiatives that enhance capacity building and organizational development among peer-run organizations, culturally and linguistically specific organizations, OHA designated or otherwise. This should include leadership training, employee training, mentorship, and networking opportunities, technology upgrades, sustainable practices. Furthermore, invest in AI solutions for translating forms and accessible electronic health record software to improve efficiency and accessibility. A section of awarded grant funding should be available to cover operational, administrative, and infrastructure expenses, ensuring that organizations can sustain essential functions. And so with all of these, I know a lot of these are very similar. They have lots of similar language. And what we will be doing is organizing the report through the various themes that we've talked about in previous slides. So we will be able to, within those themes, put these recommendations under there, and then also include any of the literature review that Jen was talking about, or any implementation, or what is existing currently within OHA's programming and things like that. So yeah, we are really looking forward to having this ready, and getting this moving on to the next steps and ready for legislation in January. So let's go ahead and go to the next slide. Okay, so this is our final slide, and we'd like to invite any discussion or questions. And I just want to remind everyone too that before we do that, is that these recommendations, as you saw, they were very focused on funding, right? So there wasn't a lot of policy recommendations. And just to reiterate that the reason being is because this first report, as we stated on one of our early slides, is focused on OHA's budget and how the legislature will possibly influence that, how it might possibly influence them. And then the next report will be focused on broader legislative actions. So just to remind folks of that. Okay, it looks like do I turn it over to you, Laura?
Yeah, yes, thank you. And just as a reminder to the committee, just wanted to remind you of the background of House Bill 2235. This bill was signed in 2023. And again, it charged OHA with convening a work group to study and provide recommendations on the barriers to recruitment and retention of these publicly financed behavioral health systems. So these recommendations will inform these two reports, as mentioned, one due in January 2025, the other one due in December of 2025. The first report will inform the legislators on what resources to commit to OHA's budget, which is really important. And the second report will inform broader legislative actions, such as reimbursement rates. So these work group members, they were recruited in December 2023. And again, these were one of the most diverse work groups that OHA has ever convened. And so with that being said, this presentation, the point of this presentation was really to share the work group's proposed recommendations with the committee and get the committee's feedback. So with that being said, we'll go ahead and open it up for questions and comments from the committee members. Rob, I see your hand up.
Yeah, this kind of goes back to my last question about the last presentation, but it also has more specifically to do with behavioral health, probably. I appreciate that you said that behavioral health includes an amazing number of people and providers, right? All the way from peer support to psychiatrists. My question is, if you didn't know this, we had a ACGME approved psychiatry program that was set to go in Central Oregon, which we don't have adequate funding for. But my question is, do you guys have representative from the highest levels of care? Because my friends here in Central Oregon that are social workers and psychologists and everyone, the lack of psychiatric and inpatient care and intensive outpatient care for the most seriously ill people is really, really bad, especially adolescents.
Yeah, Rob, I really appreciate that. And so in the House bill itself, it did not require us to have a psychiatrist in there. There was actually pre-prescribed roles for the workforce members. And even despite that, though, our starting roster, if you will, of members included a child psychiatrist, and which we were very excited about. But because of life issues that came up, that person was not able to continue, which it was a big loss to the group. And on your point as well, too, there was no requirement for us to recruit a member that represented like acute care settings, which
Wow.
which you can see in like the recommendations themselves. There's only one out of all of those that have anything to
Right.
do with acute care. And I myself, as a mental health practitioner, find that to be surprising and a little unfortunate. But we will continue to raise information that shows the need to the work group as we move forward, especially into the policy stuff later on.
Yeah, that's great because it's such a huge hole for the whole state, not just me. I mean, I practiced here and admitted patients to the psychiatric ward in Klamath Falls many years ago. And it was a huge hole then that's just gotten terribly worse. And, you know, sometimes you need a much higher level of care that any of us can provide, you know, family physicians, psychologists, whatever. And that's a real hole for my behavioral health friends, for sure. Thanks.
Yeah, appreciate that.
Thanks, Rob. Bob.
Well, looks like you're muted.
Sorry about that. Just piggybacking a little bit on what Rob had to say about the absence of workforce for adolescents, especially in the acute side. But more broadly, I'm aware that there's a committee of some sort that's being convened to address behavioral health workforce needs for youth. And so I'm wondering if that committee is an offshoot of your committee, or what is the intersection between those two committees? And are we is that information going to be coming to this group, or what's the setup there?
Yeah, I can't answer the end of that. I'm not sure what, if that information will be coming to this group. I imagine it will be. But yes, you are correct. There is the House bill. It's really, I can't remember it right off the top of my head, but the System of Care Advisory Committee is convening that work group. And yes, we will actually have one of our staff members. It might be me, it might be somebody else from our staff. We haven't decided yet. That will be a part of that steering committee. So we'll be included in things going on in that. And yes, we would love to work in lockstep with that work group. And they're fortunate enough to actually have a budget and have a facilitator, and I think they're going to do a great job. So we're really looking forward to that.
I wonder if we could make, as a committee, if we could make a recommendation or request to have that lockstep that you just referred to, Tim, be something that occurs. So we don't have the two groups kind of spinning in their own orbits and coming together and integrating the efforts, because between 17 and 364 days and 18 is not a very big jump, and then you're in two different systems. Is that a recommendation we can make, Laura? Or is that for another time?
You know, I would have to defer to Neelam and Deepthi on that.
We could probably invite them to come talk to this group, I would think, without needing a formal motion.
This is Neelam. I apologize. My voice is a little hoarse, as you can hear. So that's why I'm staying off camera. We could definitely reach out to the council and get them to provide a presentation similar to the presentation that Tim and his team are providing to us today.
Great.
We'll have to find the time to do that, Bob. We're so jam-packed for the next couple of months, but we definitely will. Maybe we could do like an educational webinar session.
Yeah. I'm under the impression, Laura, that they're just now starting. Like, I think one of their first meetings, if not the first, is a week from Friday next week. So more than a couple of months would be fine. You know, getting out there a little bit, get some work done, and then hear about what they're doing.
That sounds great. Okay, thank you for that.
Tim, do you remember who they're contracting with? I have is it the Oregon?
It's the Center for the Child and Family Center for Excellence, which is part of the Oregon Alliance.
Yes, you're right. Absolutely. That's the group they're contracting with.
And House Bill 4151 is legislation that requires SOCAC, or the System of Care Advisory Council, to convene that work group, just for reference.
Thanks for looking that up. I was wondering what the number was.
Mhm.
Okay, are there any more questions or comments for Tim or Jen? I don't see any hands up. Okay, contact information is that okay, I see Kelly's there. If anyone has any questions, feel free to reach out. Tim and Jen, thank you so much for coming to the meeting today and presenting. We really appreciate it. And it looks like we're a little bit ahead of schedule, but I think we'll go ahead and just keep on going. Jessica, if you could go to the next slide, please.
Sorry, I lost my place there.
That's okay.
One moment. There we go. That's better.
Okay. All right. We are at the point in the meeting where we are going to be talking about recruitment update, new membership elections for the Healthcare Workforce Committee for 2025. And we did want to let the committee know that we will be adding, I think it was 5 members, kneeling, if I'm correct, and 1 student from OHSU to the committee for 2025. We did things a little bit different this year with the recruitment. We put a notice out for recruitment, and then there was a group of us that met with the applicants. And like I said, it was a different process this year, but I think it was a really good process. Last year, when we did our recruitment, I think we weren't really quite clear on the commitments to this committee, the time commitment, and maybe what the committee work really entailed. So we decided this year that we would delve a little bit deeper into the applicants for the committees and making sure that the applicants understood just what I said, the time commitment, the work that the committee does. And we did have some applicants that we are going to recommend. Can you go to the next slide, Jessica? Okay. Deepti, do you want to kind of go over the recruitment process that we use, just kind of build on what I talked about?
Yeah, I would love to.
Thank you.
Good morning. My name is Deepti Shinde. I'm a new staff to Neelam's team, and I'll be lead staff for the Healthcare Workforce Committee. And I'm also the policy lead for Mark Overbeck's old position for the primary care office. So I look forward to meeting you and working with you. So I'm going to be talking a little bit about our recruitment efforts. As you know, for the past couple months, we've been going through a recruitment to bring additional members to this committee for 2025. And for the first time, we used the Oregon Health Policy Board's recruitment guidelines to sort of guide the process. We posted a recruitment notice in both English and in Spanish for a 4-week period that started in mid-September, and we got a total of 15 applicants. With those applicants, we had a review committee of OHA staff and our committee chair, Laura, that interviewed 13 of the applicants, and then we selected 6 of those candidates for consideration to be on the committee. So the new members will join the committee in January if they're approved by the Health Policy Board at their December meeting. Before we go over the new members, I would just like to go over a little bit about our current members. Next slide, please, Jessica. So we have currently 18 members that are returning or rejoining the committee for 2025. Some of these members are returning for their second 3-year term, and others are continuing with their first term. We had 2 members that chose not to continue with the committee for next year, Isa and Christian, and I think that was mainly due to scheduling availability issues, or not really having a full understanding of the work of the committee and the time involved. I'm not going to read all the names of the people that are returning, but I just wanted to say we're very thankful that so many are returning and choosing to volunteer their time and their effort with this committee. Next slide, please. So those are also a list of the names that are continuing with the committee. Next slide, please. Great. So with the new members, we'll have a total of 24 members. 23 will be voting members, and 1 will be a student that is not voting. So for this process, we use the Oregon Health Board's gap analysis tool to evaluate the current membership and identify any gaps in diversity, including geographic diversity of where members live and work, their race and ethnicity, gender, their areas of expertise, and sectors that they represent in the workforce. So these new members will help to close some of those identified gaps, and we feel really bring a more diverse lived experience and work to the committee, including, for the first time in several years, a student perspective, a licensed traditional health worker, a former member of the Oregon Health Plan, frontline experience working with in-home care and long-term care workers, and an academic perspective, specifically in rural undergraduate education. So then the members that we're proposing are listed here, and they're Kelly McKnight, Molly Reynolds, Dr. Surya Karlapathy, Tessa Christensen, and Dr. Eric Weiser, and our student member, Laura Chan. We're really thankful for the interest in the committee, and also grateful to the committee members that are continuing with the committee. Great. Next slide, please. Great. Before we go on to talk about the elections, are there any questions about the application process, recruitment process, or the members that might be potentially joining?
Yeah, the individual who was formerly an Oregon Health Plan member, would that individual be like a peer, like a traditional health worker? Do we
Yes.
have any traditional health workers who either applied or are being recommended for appointment?
Yes, that is correct. They are a licensed traditional health worker.
Great, thank you.
And we'll be providing more information about these people, their bios, at a later time as well. Okay, great. If there are no more questions, we can talk about the elections for chair. So right now, Laura is our current chair, and she has indicated her preference to not be chair again. And Laura, did you want to say a little bit about your role?
Sure. And that doesn't mean any disrespect to the committee, but I've been chair for quite a while now, and I think I said this last year too, but it's time to pass the torch. No, this has actually been one of the most fulfilling things I've done. I've been very grateful to All Care for letting me serve the time with this committee and put in the work that needs to be done. Being chair of any committee is, it's work. We all have full-time jobs. However, it does take some work. we have our meetings every other month. We have our meetings on the off months. We do have a leadership meeting once a month with the leadership of the committee, the lead OHA staff, and our Oregon Health Policy Board liaison. I would also say, even though I don't believe it's required in the charter, attending the Oregon Health Policy Board meetings I would say is an absolute must for this committee chair and vice chair, so you can really stay on top of what's happening at the policy board level. There are a couple of times where the chair might need to attend the health policy board and report out on items or seek approval from the Oregon Health Policy Board. So again, I've had the privilege of serving on this committee for many years and being chair, and I will stay on as immediate past chair. There is some work to be done next year, starting with the requirements for the procurement that I believe that, whoever is chair next year is going to, it'll be good to be able to assist that person with that, because it's going to be quite a body of work. So again, it's been my privilege to chair this committee and even serve on the committee for I don't know how many years now, maybe 6, 7. But I will, doesn't mean I'm going away, because I'm still going to be around.
That's great. Thank you, Laura. So the elections for chair will take place at the January 8th meeting in 2025. I wanted to mention that anyone can serve in these roles for chair and vice chair, whether you're new to the committee or have been with the committee for a while. And that also members can nominate themselves for these positions, or they can nominate someone else. And we are asking that you please send any nominations to Laura by December 20th. And we're really hoping to get a lot of interest and have a discussion and have a vote later on.
And I did put my email address in the chat too.
Great. Okay. Do we have any questions about the upcoming chair and vice chair elections? And please just reach out to us if you have any, questions about like what's involved and the time commitment, and we'll be sure to get those answered for you.
And I think I'll just add one more thing, Deepti. I think sometimes there's a fear of not having support and having to do these like the strategy papers and everything that we did in the past couple of years. But I always like to take the opportunity to thank the staff for this committee. I've served on a few committees for OHA, and by far this staff is amazing, and you will never lack for support when you're in any role in this committee. So kudos to the staff for the Healthcare Workforce Committee, everyone that helps. It's been amazing. So thank you.
Thank you. I think we can move on to the next slide, which is really closing remarks.
Okay, and I actually might end a little bit early today. So our next meeting is December 11th, 9:30 to 12:30. Before we end, is there anything from committee members? We haven't really done this in the past, but just kind of like, since we have a few minutes, open forum, anything you'd like to touch on, discuss, let us know. Anything from anyone? Okay, I am not seeing any hands. Okay, well, with that, thanks everyone for joining us this morning, and we will see you in December. And everyone have a great day.